So if we talk about the staging of pancreatic adenocarcinoma, tumor, the primary tumor T staging, TIS. TIS is carcinoma in situ. This includes PAN in 3, IPMN and MCN with high grade dysplasia. T1 is less than 2 cm in the greatest dimension, in which it is divided into A, B. A is less than or equal to 0.5 cm, B is more than 0.5 cm but less than 1 cm, and C is 1 to 2 cm. T2 is 2 to 4 cm in the greatest dimension. T3 is more than 4 cm in the greatest dimension. T4 any size with celiac, superior mesenteric and common hepatic artery involvement. Celiac, superior mesenteric and common hepatic artery involvement. Now N2. N staging. N0 is no regional lymph node mets, N1 is 1 to 3 regional lymph node mets, and N2 is 4 or more regional lymph node mets. And distant metastasis, M0 is no distant mets, M1 is distant mets. So stage is stage 1A is stage 0 is TIS, N0 M0. Stage 1A is T1 N0 M0. Stage 1B is T2 N0 M0. Stage 2A is T3 N0 M0. Stage 3B is T1 to T3 N1 M0. N1 is stage 2B. Stage 3 is N2 or T4, and stage 4 is M1. So if we see the survival for stage 1A is 1%. For stage 1B, that is T2 N0, is 4 cm. Stage 2A is T3 N0 N0, survival is 1%. For stage 2B, that is N1, when there is node positive, survival, what am I saying? Sorry, this is not about, this is the percentage of patients. So maximum patients are in stage 4, that is 52%. Stage 3, 29%. So now we will see the anatomical staging. So anatomical staging evaluation in case of pancreatic ductal adenocarcinoma. Surgical anatomy, the evaluation and treatment of localized pancreatic ductal adenocarcinoma requires understanding of the anatomy of the pancreas and nearby structure. And the pancreas is an elongated gland or in the retroperitoneum, and the cross of that cross the midline at the level of L2. So it is an elongated structure, and it is at the level of L2 it crosses the midline, and the pancreas is bound anteriorly by stomach, posteriorly by IVC, aorta, left adrenal gland and left kidney. And descriptive anatomy of the gland is grossly separated into 4 components. Head is the rightmost portion and sits within the C loop of duodenum. It includes parenchyma to the right of the superior mesenteric vessels and contains the uncinate process, which projects inferomedially extending to the right lateral border of the superior mesenteric artery. And the common bile duct runs within or rarely just posterior to the pancreatic head and enters the duodenum at the ampulla of Vater, usually with the main pancreatic duct. Moving leftward, the neck of the pancreas lies anterior to the superior mesenteric vein, portal vein axis, and the superior mesenteric vessels run posterior to the pancreatic neck and course inferiorly across the anterior border of the third portion of the duodenum. Body and tail of the pancreas extends to the left of the superior mesenteric vessels, and the gland transition distally into the pancreatic tail anterior to the left kidney and crosses towards the splenic hilum. Now, anatomical resectability criteria. Several organizations have published consensus definition of anatomical resectability, including International Association of the Pancreatology (IAP). The central tenet of anatomical resectability is likelihood of achieving negative margin. So margin negative resection is the main thing for in case of pancreatic duodenectomy, and this is influenced by the degree of involvement of the tumor, then pancreatic blood vessels, SMV, portal vein, SMA, common hepatic artery, celiac axis. So R0 resection is the main thing for any anatomy anatomical resectability criteria for pancreatic surgery, and in that case we have to see the tumor, how much is the tumor burden, then what is the status of vessels like SMA, then common hepatic, SMB portal vein axis and celiac axis. And anatomical resectable tumor have a high probability of R0 resection. Borderline resectable tumors have a high probability of R1 microscopically positive margin resection in the absence of neoadjuvant treatment. Locally advanced tumor have a high risk of R2 resection, that is residual macroscopy. And data from large institutional cohort studies demonstrate poor survival in patients who undergo surgery first approach, resulting in R1 resection margins, that is John Hopkins 14 months, Mayo Clinic 15 months, and Massachusetts General Hospital 14 months. While cross-sectional study comparisons are not possible, similar survival has been reported for patients with the metastatic non-resected pancreatic or ductal adenocarcinoma who receive intraoperative radiotherapy and systemic chemotherapy with or without radiotherapy, suggesting a lack of oncological benefit of upfront resection that results in R1 margin. So consensus anatomical resectability criteria are summarized in this table. So what this table says that anatomical classification: resectable R0 resection, likely in case of SMV portal vein less than 180 degree abutment, celiac axis no contact, common hepatic artery no contact, and SMA no contact. So this is pancreas. First there is this SMV, and there is SMA, and SMV portal confluence. And suppose the tumor is here and it is involving less than 180 degree with the SMV portal vein confluence, then it is likely resectable. Borderline resectable, that is R1 resection likely when the contact is more than 180 degree, when this SMV portal vein contact is more than 180 degree without occlusion, or any contact with occlusion, that is reconstructible. But if it is involving celiac axis or common hepatic artery, celiac axis less than 180 degree abutment, SMA less than 180 degree abutment, then it is borderline resectable. Any common hepatic artery abutment. Local advanced R2 resection likely in case of non-reconstructible mesenteric venous involvement when celiac axis contact abutment of more than 180 degree, SMA contact abutment of more than 180 degree, and common hepatic artery any abutment but not reconstructible. Okay, so borderline resectable lesions have a visceral vessels, arterial contact as less than 180 degree, and if SMV portal vein involvement exists, reconstruction is technically feasible. In locally advanced, more than 180 degree contact with any of the aforementioned arteries or occlude SMV portal veins, there are no reconstructing options.